Oh, thank you very much. It's a very kind introduction. Thank you for the invitation. I'll just share my screen. Well, it's going to be a similar talk to the one I gave in Paris, and let me just pull it up. Hopefully, it will stimulate some questions. It's early in the morning for us here in the UK, so apologies if I'm still a little bit sleepy. So I'm going to talk about laser and how it works in the coronary system, and this is the overview. So I'll just start really with talking about what laser is in principle. So light amplification by stimulated emission of radiation is the absorption of light that we're really interested in. And as that gets absorbed into tissue, that energy is used to break down the material. So within the laser system, which Philips is the only FDA approved one, we have the xenon chloride gas, an excitation mechanism, which is electricity, pulls those molecules apart, produces the photon, and that process is repeated continuously and allows us to generate this light energy. It's not just the light energy which we will use, as you'll find out as I go through. This is the actual hardware itself. So the laser machine is quite a bulky device. This is the first generation machine. This is what we had in our catheter labs for many years. There's principles the same. We take a catheter, we calibrate the machine first of all, and then we calibrate the catheter, and then we're ready to use. And this particular catheter is a 0.9, very thin, very easy to use. That pictures of the next generation, but this is the very latest model. It's fantastic. It's really small compared to the previous one, much lower footprint, and you can see the weight reduction is about 26%. Calibration is identical. You hold the catheter against the machine, but now there's a touch screen which really facilitates much easier moving around from different energy settings, which I'll talk through in a second. In terms of the catheters, there's obviously not just coronary work, but there's lead extraction, which you'll hear about later. The coronary catheters, there are 4 catheters. The 0.9 is the only one to worry about or think about. It offers the maximum energy and the highest laser settings. You get 10 seconds of lasing versus 5 seconds rest. The 1.4 is a 6 French compatible, but has lower energy settings, 1.77 French compatible. And then the largest catheter is 2.0 and is 8 French compatible. But those all have lower settings in terms of power. How laser works, first thing is the light breaks up the molecular bonds, and this is quite important. So we have to allow the light to penetrate into the tissue. So it's a very slow process when we're delivering laser energy. So as the laser light goes into the tissue, it starts to crack these molecular bonds, and that weakens the tissue. Now, the laser itself is ultraviolet light, so it's very sort of shallow penetration depth, about 50 microns. So it's very small, and it doesn't damage the adjacent tissue. It just focuses really on the area of interest. Once it starts to break up the bonds, then we can get into the next phase, which is really the sonic wave, which is emitted from the catheter tip, which breaks up things further and penetrates out from the tip of the catheter, a little bit like the way that the shockwave system works. This will penetrate into the deeper tissues and will help to break up the more fibrotic tissue and potentially calcium, which is maintained in that lesion. The third step is you have this cavitation effect. So this formation of the vapor bubble is creating this sort of sonic energy to mechanical energy, and it's clearing into the tissue and breaking down these products. They're broken down into tiny, tiny particles, which are absorbed in the reticular endothelial system. They don't really get any problem with no reflow, sometimes what you might see with rotablation. So those are the sort of 3 mechanisms described, but they're all working at the same time, and they're all working in a very short period of time. Now, the thing about laser, it's a very easy technique to learn. The first thing is you have to just move things very slowly. I've said that the light penetrates to shallow penetration depth, but you just move it incredibly slowly into the lesion, and that gives you the biggest lumen gain. If you move it too fast, it hasn't got time to work. So in this situation, we go slow to finish fast. Power settings, there are 2 basic sort of settings you can go for: the lower settings and the higher settings if you've got more fibrotic tissue. Now, using it in saline is very important because that reduces the risk of penetration into deeper tissue and reduces the risk of dissection and perforation, as you can see in this test tube model. If you use it in contrast, you get.
So how we do it in this lab is we set up with the 3-way tap. We have saline put onto the side of the three-way tap. Then I disconnect the contrast and I put that on the top of the three-way tap, like so.
So that's just how I set up in the cath lab, but you don't need to do it that way anyway, as long as you're injecting saline as you're lasing. Now, the laser, you can change the frequency. So this is the second number. The first number is the power. The second number is the frequency, and you can change that if you've got more complex lesions. This is just a useful paper for people starting out in laser. It's a 10-minute read, and it gives the tips and tricks and gives some of the indications. Now, I'm going to talk about how we use it in clinical situations, and the three I've picked where I think it's most useful is in non-dilatable, non-crossable lesions is the first real group. This is where I really first started using it. Restenosis, I think, has got some good applications because of underexpanded stents plus near-intimal hyperplasia. And lastly, thrombus, it works very effectively, and I'll show one example of that. And as I've alluded to, you can change the settings of the device to allow you to deal with this more different range of indications. So if you've got soft plaque, you don't need so much energy, so you can go with lower settings. You might go with 25 and 40. But if you've got hard material like calcium, you've got CTO, then you're going to go with the higher settings and go with that right at the very start. It's much more efficient. So if you have a non-dilatable lesions, we know there are several options of treatment that we can offer. We can go from cutting balloons, scoring balloons, and so forth. And in this situation, I think imaging is very useful. But of course, at the start of the case, you may not be able to get the imaging catheter down. No matter, I don't think whether you use IVUS or OCT, gives useful information. So in this particular case, this was the CTO of the LAD, as you can see. It gets wide, true to true with I think a miracle wire. So it's quite an old case. But that balloon doesn't expand, very focal lesion. And we've got different options, but we're going to use laser in this instance because it's very straightforward. It's on the same wire. We don't have to change wires. Any 0.041 wire will do, and it will deal with an uncrossable and non-dilatable lesion very effectively. So only about 4,000 or 5,000 pulses necessary. Here's a more recent case: 68-year-old patient with a calcified right coronary artery, has a mitral valve in place, and has severe renal impairment. So this is ultra low contrast PCI, as you've heard before. Here is the anatomy. You see there's a tight lesion in the right coronary artery mid-vessel. The balloon does not expand. It's quite clear. So we go straight to laser here, 80-80, deliver 15,000 pulses, which is quite a lot to get through, actually. It's quite a resistant lesion. But then the same balloon then expands. And at this point, we can then pass a IVUS catheter through the lesion. And what we see on IVUS is a bulky plaque, significant calcification as you come back into the proximal vessel. And we see some modification in the lesion. And that's probably been caused by the balloon following the laser, but obviously we couldn't get the balloon to expand before laser. Then we put a biofreedom stent in, and we get a good result angiographically. And again, we use the imaging to confirm that we have good stent expansion. So I think laser fits in really well into the toolbox when you have this type of stenosis, which is resistant to normal balloon technology. What about if you cross with a wire, but then you can't get anything else to follow? This is not an infrequent occurrence, particularly in the CTO work. Clearly, balloon technologies here are going to be ineffective, scoring or cutting or shockwave. And most atherectomy is tricky because you cannot get a microcatheter to cross. Laser here is a really good, obvious choice. But if the microcatheter crosses, then of course you've got options. You can use rotor, you can use orbital. But if it doesn't cross, then rather than going through multiple balloons, I think the best thing to do is to use laser, because I know it's going to work. So in this particular case, we wired again, fairly true to true, straightforward CTO. A small balloon that we had at the time did not cross, and neither did a microcatheter. So we use laser, 5,000 pulses, and we get the case done. So you can see laser really is just a step to get the case completed. So this sort of technique of not crossing or not dilating the lesion, we go straight with laser, it works, and then we get a good result with our stent. This is a more complex scenario. We have a patient who's got an impaired left ventricle, ejection fraction less than 35%. That's the anatomy, a tortuous calcified right, which is looks very unattractive for PCI. A left system with a severe circumflex and severe LAD stenosis. The patient has an overall high jeopardy score in terms of the coronary anatomy. MRI shows that most is viable, and we do a CT up front to look at the peripheral circulation because we're thinking about an impeller. in this case. And in fact, this is a trial we're doing in the UK called the CHIP VESIS-3 trial, randomizing patients to Impeller or not Impeller for these complex cases. This patient qualifies on the basis of a high jeopardy score and high burden of calcium, so we have to modify. And this patient is randomized to having PCI with Impeller up front. So I get my colleague, I don't do TAVI in our center, so I get my colleague to come across and we do this large bore access together. He's a TAVI operator and we get good results. So here's an Impeller being implanted into the left ventricle at the start of the case. And this is the actual easy bit of the case, because what follows is more tricky. When we start the PCI, we're 6 French, we've got an EBU 3.5. I can't get anything to cross that circumflex stenosis. No balloon or Corsair, nothing will cross. It's very tortuous and calcified. Now, this is not the easiest case for laser because it's tortuous and calcified and maybe a relative contraindication, but I use the laser here just to get me through about 75% of the lesion. And that's enough to modify the situation. And then I can get a balloon across, which then is really safe. And then I can get my microcatheter down, which was, even despite the laser, is still quite tricky. But once I get that past the lesion, I can switch out for a rotor wire and I can use a 1.5 millimeter burr. This is clearly a very calcified lesion and we need to get good results for these patients, particularly in a trial. So we use a 1.5 burr, we get good debulking, we switch out for a grandstand wire for extra support, and with GuideLiner are able to deliver 3 stents and get a reasonable result in that circumflex. The LAD is much simpler, doesn't require laser, we just put a microcatheter down, switch out for a rotor wire, 1.5 burr, ultimately go on and perform shockwave as well, because you'll see the calcium burden remains high despite the rotor on IVUS. It's 360 calcium, not that much reverberation, so we feel this is probably deep wall as well as superficial. So we go ahead and use the 3.5/12 shockwave. So an expensive case in terms of equipment. Clearly we've used Impeller, rotor, laser, and shockwave. But we get a good result in these vessels. That's the procedure data, so tiny troponin rise and the patient goes home the next day. And this is all part of a clinical trial, so it's good. Now, when we combine these technologies, laser and rotor, we call that RAZOR. We first did the case in 2008 and published it in Neurointervention, and that's why we coined the term. Here's a more complicated case, 86-year-old patient, again, with a poor ventricle with an acute coronary syndrome. And this is the left main into LAD. You can see it's a complex lesion with a high burden of calcium and nodule, and it's a very severe stenosis. And this is really the last remaining vessel. So we did this without any hemodynamic support, and it was a challenging case. So with 7 French from the left radial artery, we get a wire into the LAD, we get a wire into the circumflex. Microcatheter will not travel into that circumflex. There's no real option, into the LADs. There's no real option to rotoblate at this stage, even though that was my initial intention. Tried a variety of different mechanisms to get down into that LAD with microcatheters, including balloon anchoring in the circumflex. But this is clearly a laser case for me. So we take a 0.9 laser, but in fact, again, we're having to push quite hard in this calcific lesion, and you just keep going there, keep maintaining the pressure. Don't over push, because that will potentially then shoot forward and cause trauma. So you're just pushing gently up against resistance and allowing the laser to do its work. Now, after about 10,000 pulses or so, it starts to make some good progress. When it meets a lot of resistance, I then stop in this complex type of lesion and then take a balloon back. I don't keep going with laser to get 100% through the lesion. All I'm trying to do is modify things so I can get other equipment through. So that's what I do at this point. When I get too much resistance, I think, well, I'm not going to push it any further, take the laser catheter out, switch for a balloon, and then we're able to make some space. So once the 2.0 Sapphire then crosses and then able to get the wire down, you can see there, the wire was kind of stuck in the lesion and wouldn't go any further. Obviously, having a distal wire gives us more support for the lesion. And once we're able to then deliver the 2.0 balloon, I'm feeling like we're making progress, and the balloon actually does start to expand, but not fully. I take a bigger balloon. I'm not convinced it's fully expanding. So we go with our original plan and we use the 1.75 millimeter burr. to rotablate through that proximal lesion. And then at this point, we're able to do some intracoronary imaging. And actually what we see is that there's still a very significant amount of calcium. I haven't shown the imaging here, but you can see on the fluoroscopy, there's a huge burden of calcium. So it does require shockwave as well. But we get a very good result, which I think, given that this was an important vessel, it was an important aspect to get right. So sometimes you have to combine these equipment. And when we've combined all three, we've given it the name Razor Shock. I mean, none of this matters, but you can just see it's all about using the tools. The restenosis, why is it useful for restenosis? Well, I think there's two potential mechanisms here. First one is you have an underexpanded stent. And secondly, if you want to clear all the material. Now, I first had experience of this back in 2009. This was the patient I was treating, 80-year-old. It initially came in with a calcific LAD, pressure I was positive. I treated with a 2-burr strategy because that's what we had in 2009. We used rotablator a lot at 1.5 and then a 2.0 because the balloon didn't expand in between the burrs. Now, after that 2.0 burr, I took more devices because it still wouldn't expand. I took cutting balloon, I took non-compliant balloons, and I could not get this lesion to expand. The imaging told me that why this was, because it was clearly a napkin ring calcific stenosis. And I made a mistake at this point because I thought, well, if I put a stent in, I'll be able to go to high pressure with an OPN balloon, and I'll probably be able to resolve this. So that's what I did. I put a bare metal stent in, which clearly was not the best thing to do. And despite going up to 40 atmospheres with OPN, I still had an underexpanded stent. So I brought the patient back 2 weeks later, had some phone calls with colleagues in the US. Not many people had done this treatment with laser for underexpanded stent. You can see the IVUS shows again the napkin, but this time within a stent, which is clearly a very dangerous situation for the patient. We took 2 laser catheters, a 0.9 and a 2.0. I think the 0.9 did all the work. And then the same balloon that I'd used previously went up and it was magic. And it was one of those moments in your career when you think, well, something's really different here and this device has worked. And nothing else I don't think would ever have worked. So for me, laser for underexpanded stent works quite well. You don't have to use it with contrast as that's off-label. You can if you've got very resistant lesions, but a lot of the time you can do it just with saline. So there has been some publications in this area. This is the registry from the Milan group, and they did use contrast in their population, relatively small number of cases, and they got very good results with this is obviously a very high recurring population who come back with MACE. There's been more case reports, and I think this is quite a nice paper in neurointervention. It shows that how laser works really is by affecting the peristent calcium and fractures it, and the tighter the lesion, the more gain you can get with laser. So in this short talk, the final indication I think for laser is for me is thrombus. We did a lot of cases with thrombus in the early years when we had primary PCI. One of the reasons it works well is because a thrombus naturally will absorb light of this wavelength. And these are some very elegant experiments done by, I think, the real hero for laser, which is Professor Onto Powers in the US. He's published huge amounts on this. And he took platelets and that were exposed to collagen and ADP aggregation and showed that basically laser light inhibited that aggregation. It prevents the platelets from sticking together, and that obviously is a very useful thing. So in this situation where we have a previous stent, a taxus stent and a stent thrombosis presenting very late, we do some ballooning, we get very little flow in the vessel. We perform some imaging, which really tells us that there is multiple mechanisms at play here. There's clearly underexpanded stent, positive remodeling, but within the stent, you can see there's lots of thrombus there. And this is a tricky thing to resolve. If you keep ballooning, you run the risk of distal embolization, and you may not get any benefit in any PCI here. Sometimes you might give just drugs, so you might give a 2B3 inhibitor and wait. But there was quite a lot of mechanical issues, I think, that needed resolving here as well. So I didn't really want to stop and do that. So the plan here was to use laser. So we gave a 2B3. You can see the angiographic thrombus, which fits with what we see on IVUS. I open up that PLV initially, and then I moved to laser. and I use a 0.9 catheter. You could use a bigger catheter, but you'd have to use sometimes a bigger guide. You go with 1.4, I guess, with 6 French. And then after lasering, we laser from proximal to distal, and I think there is a bit less thrombus, perhaps. I haven't measured it, haven't quantified it, but importantly, patient obviously is very stable. We have TIMI-3 flow. We haven't got any embolization, and that's a good situation to be in when you're in this type of setup. So then I are able to then, having I think cleared most of that thrombus, to put some new stents in, because these are first generation stents that were there before, and we stent from the distal vessel back to the proximal vessel, and we get a great result. And when I've used laser in this situation before, I generally get very good results. So my summary table, these are the different devices in comparison. I think laser is not the best for heavy calcification, but it's good for moderate. It's perfect for underexpanded stent.